Now, with that, we will go into the discussion of hyponatremia, approach to hyponatremia. And as I told you, whenever you have a patient with low sodium, you have to look at the volume status of the patient. So here's a beautiful screenshot from Harrison, which itself is taken from Schreier's textbook of nephrology. If you look at the footnote, so the assessment of volume status, categorize your patient to either a hypovolemic, euvolemic, or hypervolemic individual. So in a hypovolemic individual, as you can see from your screen, let me go to a laser pointer. As you can see from your screen, there is a depletion of total body water and depletion of total body sodium. That's what happens in hypovolemia. Okay, let's go to euvolemia. Come to the center part. We'll go step by step. In euvolemia, there is apparent euvolemia. Okay, there is apparent euvolemia. Actually, the total body water may be increased. Total body sodium may be normal. So relative to the sodium, since the water is more, there is hyponatremia. And in hypervolemia, the total body water is much more when compared to the total body sodium, which is also increased, and therefore the patient is having dilutional hyponatremia. Okay, the patient is having what you call typically the dilutional hyponatremia. So from this, once again, we have to reiterate, re-emphasize the concept that low sodium or any sodium disorder, low or high, is actually relative to the water content in the body. Relative to the water content in the body. Okay, so if you look at it, total body sodium is actually more in hypervolemia. Now that's a very, very important concept that you have to understand. Why? Because when you talk about hypervolemia, let me take a minute and talk about hypervolemia here. You know the causes. Okay, you know the causes. Whenever there is renal loss of sodium, then probably it is an acute or a chronic renal failure itself. And if the kidneys are okay, then they are supposed to conserve the sodium. Okay, they are supposed to conserve the sodium because there is hyponatremia, right? That's the concept. If you actually keenly notice, we discussed that normally the kidney can excrete up to 100 milliequivalents per day for you or me, right? We don't have hyponatremia. And if you check a urine sodium, that is why when you look at the lab report of urine sodium, the range will be somewhere 20 to 100 and all those things. So that's there. But in hyponatremia, when the serum sodium is low, when the kidney is the organ responsible for the sodium homeostasis, then what do you expect the kidney to do? The kidney has to conserve all the sodium. It is not supposed to excrete sodium at all in the urine, right? That is the normal response that you expect of the kidney. And that is why the next step after assessing the volume status is to see whether the kidney is actually conserving the sodium or letting go of the sodium. Letting go of the sodium is inappropriate response, right? I hope you got that concept right. So that's the importance of the test called urine sodium, like I told you. Okay, the importance of urine sodium after assessing the volume status is very, very important because you want to know whether the organ responsible for sodium maintenance, homeostasis, sodium balance is appropriately responding to this stressful situation. So it is supposed you expect the kidney to conserve the sodium. If it is losing sodium, then the problem is in the kidney itself. Okay, either an AKI or a CKD, or otherwise the problem is elsewhere. Problem is elsewhere. Okay, either a liver failure or a heart failure in particular. Liver failure or heart failure in particular, where there is more sodium, more water in the body compared to sodium. There is more sodium also. Once again, look here. Because when you have liver failure or heart failure, suppose the patient is admitted with acute decompensated heart failure in the cardiac unit in your cardiology department, what is the treatment that you're going to give in heart failure? Okay, patient may be having hyponatremia, but the treatment that you're going to give is Lasix, right? You're going to give Lasix, you're going to give furosemide, you're going to give some form of diuretic so that the patient loses this excess water, You treat the heart failure so that the dilutional hyponatremia becomes okay. Okay, becomes okay. Now, this is a very, very important concept that I want to tell you. Heart failure is a sodium avid state. Okay, it is a sodium avid state. Your body is madly trying to conserve sodium, and your heart is trying very hard to excrete the sodium. That is why you have a lot of natriuretic peptides that are increasing in your heart failure. Okay, a lot of natriuretic, because there is a lot of sodium in the body already. Okay, in heart failure there is already a lot of sodium in the body, just that there is even more water, and therefore your patient is having hyponatremia, and therefore you have to get rid of this water so that you can help the patient. Okay, the heart also should become okay, sodium also should become okay. That is why diuretics are a cornerstone of treatment in this. You want natriuresis. That is what your body or your heart is trying to do. So much of BNP, natriuretic peptide. Okay, isn't it called the natriuretic peptide? Because there is so much sodium in the body, the heart wants to get rid of the sodium. It is secreting natriuretic peptides, and we as doctors also must help in the process. Because when you look at so many different kind of the memes or the comedy things that come on the internet, which pit the cardiologist and the nephrologist against each other, right? It is usually in the topic of diuretics, okay, where cardiology wants to give a diuretic and nephrology doesn't. So I for one want to think that there is actually no uh, uh, contradiction at all. Okay, there's no contradiction. It's a sodium avid state. You have to get rid of the sodium. You have to get rid of the sodium by giving the diuretics. I hope you got this concept loud and clear. So that's about hypervolemic hyponatremia. Okay, more sodium, even more water, leading to a dilutional hyponatremia. You check for your urine sodium. So the urine sodium is more, than it's probably due to AK or CKD itself. And if it is less, then it is either going to be a third spacing secondary to any losing disease like a nephrotic syndrome, or more commonly a liver failure and your heart failure. Okay, patients developing hyponatremia, the background of nephrotic syndrome is not so common clinical scenario. Don't think about it. Think about cirrhosis and think about cardiac failure. And I told you about the important concept in cardiac failure. Sodium avid state, out of natriuretic peptide, body is already struggling, give diuretics, help the patient. Okay. Now, coming to the first thing, hypovolemic hyponatremia. Okay, patient is dehydrated, has less water, less sodium. You again want to see, one second. Yeah, so the concept of thiazide and Lasix. Okay, let us go for it. I will discuss that point. Okay, I have taken your question. There is a slide addressing this point, and we will see to it in the subsequent slide. So I request you to wait for some time. Okay, we will answer that question. So there's somebody who's put in the chat box comparing the effect of furosemide and thiazide diuretic on hyponatremia. Okay, Lasix will cause free water clearance, hence in heart failure. Understood? That's where you have to actually change your concept a bit. We will discuss that. Okay, essentially the question is the difference of furosemide and thiazide diuretics. We will talk about it. So coming to again hypovolemia, you again want to step two. Step two, again, you want to see whether the kidney is responding properly or not. If the kidney is responding properly, the problem is not in the kidney, your urine sodium is going to be less than 20. So you have some extrarenal loss, whatever. GI loss, vomiting, diarrhea, third spacing of fluids, burns, pancreatitis, trauma. Okay, I don't want to go through it by much. Okay, one second. Yeah. So this is where your extra renal losses, and sometimes you can have renal losses, a remote diuretic use, ongoing diuretic use, okay, salt losing nephropathies, okay, some interstitial nephritis, medullary cystic kidney disease, reflux nephropathy. All these are disorders which are salt losing deficiency. Okay, your renal tubular acidosis, your ketonuria, any osmotic diuresis, the cerebral salt wasting syndrome, all different kinds of diseases where there is a problem outside the kidney leading to dehydration. Okay, leading to dehydration. One important thing that I want to tell you here is your mineralocorticoid deficiency. Okay, mineralocorticoid deficiency. One common scenario we see in India especially where tuberculosis, although declining, is still very much present in clinical practice. You can have a secondary adrenal insufficiency. Okay, secondary adrenal insufficiency. This point is particularly highlighted in your Harrison also, where you can have a constellation of features. Okay, constellation of features, particularly when you have a patient with hyponatremia, hyperkalemia, low or normal blood pressure, okay, with the urine sodium less than 20, okay, but there is no hypervolemia, then you want to think about your mineralocorticoid deficiency or hypoaldosteronism. Okay, this is what because aldosterone is very important for potassium excretion. So there will be hyperkalemia as well. So hypoaldosteronism, you will have this constellation. So you can expect an MCQ with a clinical vignette, clinical case scenario, where you can have your adrenal insufficiency causing this kind of a thing. Can be an Addison's or it can be a secondary deficiency like tuberculosis. As I told you, tuberculosis invading the tuberculosis can cause hyponatremia in any which way, actually. Okay. It can cause a syndrome of inappropriate antidiuresis also. It can cause your hypovolemic hyponatremia through your hypoaldosteronism secondary to adrenal insufficiency. So many which ways where tuberculosis can cause hyponatremia. So remember this concept, hyponatremia, hyperkalemia, which is the function of aldosterone, low normal BP, urine sodium is low. So all this has to point towards a diagnosis of adrenal insufficiency, right? Very much highlighted in the text paragraph of Harrison as well. Okay, so that is about your hypovolemic hyponatremia. Here, what do? You just give saline to the patient. You give him sodium chloride, normal sodium chloride, 0.9 percentage, and you will have a magical response. You will have a magical response. You don't even have to use your 3% sodium chloride. 0.9 percentage will do the job for you. Coming to the middle point, your euvolemic hyponatremia. Euvolemic hyponatremia. Here there is clinically no edema, but there is a little more body water when compared to the sodium. Three main causes. The most frequent cause is your syndrome of inappropriate antidiuresis, SIAD. Okay, SIAD. The cause of SIAD may be whatever it is, but SIAD is the most frequent cause of euvolemic hyponatremia. Number two is your glucocorticoid deficiency, and number three is your severe hypothyroidism. Okay, severe hypothyroidism. These are the three reasons.